Nice to see you today. My name is Phrom Mham Saeng from Sikarin Hospital, Bangkok, Thailand. It is my great honor to be here. Today, the topic is all about rotator cuff repair using the biceps augmentation. And my talk is about the management of irreparable cuff tear. And at the end of my presentation, I will discuss about do we need to cut the distal bicep segment after using it as a local graft? Overview. I'm going to touch on the management of irreparable cuff tear. We are going to talk about the techniques and evidence of long head biceps augmentation. And I will answer the question, do we need to cut the distal segment at the end of this talk? Because we cannot close the gap of the irreparable cuff tear, we just cannot bring the tendon back to the anatomical footprint. So we need to use the biceps tendon to fill the gap or to augment our cuff repair. And what is the irreparable cuff tear? There are many studies that propose the following definitions. Basically, irreparable cuff tear are large defects. They are usually more than 4 or 5 centimeters. Acromial-humeral distance is narrow, usually less than 5 millimeters. Fatty degeneration, Guttarier grade 3 or 4, and the tendon retraction to glenoid level. All of these are the factors that we use to predict the irreparable cuff tear preoperatively. As you can see, there are many surgical options for a patient who has irreparable cuff tear. We have bicep augmentation, SCR, tendon transfer, and we also have the reverse. Regarding management of the irreparable cuff tear, if the patient has severe medical conditions, low demand or mild symptoms, we can choose conservative treatment. However, patients who already have arthritis or cuff arthropathy, Hamada grade 3 or 4, and they are over 65 years old, reverse shoulder replacement may be a better option. But in our practice, the majority of irreparable cuff tear patients, they are active, high demand. Some may have pseudoparalysis, severe symptoms, and they don't have cuff tear arthropathy. What is the best treatment for this patient? We have many treatment options, as you can see, for this group of patients. With each option, there are advantages and disadvantages. As a surgeon, you need to know the pros and cons of every procedure that you are going to recommend to your patients. And today, we are focusing on just one procedure, the partial repair with biceps augmentation. We can use long head biceps to augment in irreparable cuff tear. The techniques can be divided into 2 groups. The first one is using the biceps as a soft tissue interposition to bridge the defect. Professor Yonggali, Professor Itoi, and Professor Abrams have proposed their surgical techniques with good results. The second group of biceps augmentation is what we call superior capsular reconstruction. There are some variations of these techniques. Basically, we fix the biceps graft at 2 points. One at supraglenoid and another one is at greater tuberosity. Supraglenoid, greater tuberosity, supraglenoid, and greater tuberosity. Imitating the native superior capsule. As you can see, there are many options. Different surgeons have tried different procedures and have made different recommendations, but we still lack long-term clinical results. And recently, we have 2 clinical studies that report good results from biceps SCR. We have soft tissue interposition and we have SCR from biceps. Now let's look at some studies from Korea and Japan. The first study is from Professor Yonggali. He has 37 shoulders and conclude that biceps augmentation was effective in achieving fewer structural failures. The healing rate is 58% in augmentation group and 26% in non-augmentation group. Among the two groups, they have same clinical outcomes. Professor Itoi from Japan performed open surgery and used biceps tendon as a patch graft. He has nearly 100% complete healing rate. However, this study from Korea found no significant difference in the clinical outcomes and repair rates between biceps augmentation and partial repair without augmentation. Additional biceps augmentation appears to have no benefit in tendon healing. The repair rates were the same, it's about 40%. Finally, this systematic review shows that only 8 studies meet the same criteria as high quality studies. The studies are only small case series without control groups, and they conclude that no recommendations to do biceps autograft augmentation could be provided based on current evidence. Now I think you can see the overview picture of where we are right now with biceps augmentation. And obviously, we still need many more biomechanic and long-term clinical studies to draw definite conclusion. I've already talked about the principle and the clinical studies of biceps augmentation. Now it's time to answer this question. The question, should we cut the distal segment of biceps augmentation like this? Why is it important to know whether we cut it or not? After extensive research, I have to admit that I still don't know the right answer yet. I found that nobody has focused on this particular issue before, and there is no evidence supporting it either way. Maybe in the Q&A session, we can discuss with our senior surgeons, Dr. Yang Su and Dr. Bancha, Dr. Chanaka, Dr. Ekavit can help us. Perhaps with their expertise, we will learn the answer today. However, if we consider the blood supply of the long head biceps tendon, its main blood supply is from the circumflex humeral artery that run from distal here to proximal. So if we cut the distal segment of the long head biceps, we will definitely cut the blood supply to the more proximal part that we use it as a local graft. We will be changing from vascularized tendon graft to non-vascularized tendon graft. This may decrease the healing rate, and we can have graft necrosis and may increase the risk of infection. So my assumption is that we may have a higher possibility of graft healing if we preserve distal segment of long head bicep, because we don't cut the blood supply from the circumflex humeral artery. What if the biceps tendon have pathology in the groove or below the groove, as Professor Yongeri described as a hidden lesions? The patients will have postoperative pain in the bicipital groove. To avoid that, we may need to cut the biceps distal to the augmentation point, and we may add another fixation as a biceps tenodesis in the groove or subpectoral biceps tenodesis, or we just leave it as a biceps tenotomy. Unfortunately, we could have inflammation or other pathology distal to the augmentation point, as in this picture. So we have to cut the biceps and do the tenodesis or just tenotomy. In summary, we can classify the surgical techniques of biceps augmentation into two groups: soft tissue interposition and SCR. These days, there is no recommendation to do biceps augmentation based on current evidence. Regarding the distal segment of biceps, don't cut it because you may risk cutting the blood supply of the graft. But if there is pathology below the groove, cut it. Thank you.
Thank you, Try. Very nice talk. So
Now we have
you
a question.
Besides, you are staying with Yangsu or with Chanagan and Egavit?
Just between.
Just between. Okay.
Depend on the pathology.
Okay,
Totally, yeah, I totally agree with the try. It's
Yes.
and this point is blood supply. The maintain the vascularity is very, very important, I think.
Yeah.
And even though there is a little bit degeneration or partial tail lesion in the groove,
Yeah.
when you have to remove at the reroute and we fix the biceps to the bone, there's no moving anymore. So I think pain is coming from the friction.
Yes.
Friction in the biceps groove. Biceps is dynamically moving tendon, but if you fix to the bone, this bicep tendon, this is the effect. There's no more motion.
Yeah.
No motion anymore. So we can prevent pain or further damage after fixation. So we can do we don't need to cut the biceps after it.
So Yangsu, there's one question. They're asking you dilute the bicep. You change the vector force of the bicep from front to the side. So that still have the vector force that try to pull the bicep back, you know?
Yeah.
So you fix only one anchor, right? Now your new technique. Is that enough? Because the force of bicep is too much. Sometimes the bicep can slip back.
Okay, good. So with one fixed biceps with lateral low, it's a three strand. So I'm using the three strand, the grab the biceps 3 times. Sometimes the 2 strand is I think enough. And then the other thing is making the groove more deeply than original concept.
Oh yeah.
So is grooving the biceps is
the
a
big trough, right? Big tunnel.
Yeah, trough. Yeah, big trough.
Yes.
Is grab the biceps, and then medial anchor. Have an insert to the medial anchor. Insert to the anterior posterior using the 2 anchor. One is the anterior, and the second is the posterior to the biceps. So they make a not fix the biceps itself, but restriction the biceps moving. So I think
trap it, right? Yangsu, you trap it into the trap.
That's right, trapping.
Yeah.
So this is